Hello and welcome to History of Disease. My name is Ryan, and today we are going to be discussing a disease which has become rampant in the United States, but which many people know very little about. Spread by the seemingly innocuous bite of a tick, this disease can lead to a host of debilitating symptoms, from joint pain to heart disease, even to infection and inflammation of the brain itself. It can strike quickly, leaving its victim unable to walk, or more insidiously, laying dormant for months to years. This mysterious ailment? Lyme disease. Dr. Alan Steer leaned back in his chair, confused at what he had just heard over the phone. He had just gotten off of a call with an old colleague at the Center for Disease Control who had phoned to tell him about a strange series of arthritis cases in a small town in Connecticut. Knowing that Dr. Steer had just begun a fellowship in rheumatology at Yale University in 1975, his old friend figured that he might be interested in the cases. He had told Dr. Steer about a conversation he had had with a pair of mothers who had phoned the state health department, concerned about the number of children in their town who had recently been diagnosed with juvenile rheumatoid arthritis. This struck him as odd. Rheumatoid arthritis in children was not unheard of, but it was quite rare. If you took an NFL stadium and filled all the seats with children, you would probably be able to count the number of kids with the disease on only one hand. In a town of only about 12,000 kids, it would be quite the statistical fluke to have enough of them to raise the concern of the two mothers. Dr. Steer's friend had also told him that, if he was interested, he should get in contact with Dr. Gifford, another Yale rheumatologist who had been treating some of the afflicted children. Intrigued, he decided to meet with Dr. Gifford. He was taken aback, though, when the doctor casually remarked about a family he was taking care of in which all 4 children, as well as both of the parents, had been diagnosed recently with rheumatoid arthritis. Fascinated, Dr. Steer knew that he had to see these patients for himself. Dr. Gifford told him that the family could be found in a small community about 25 miles to the west. The name of that town? Lyme, Connecticut. After taking a quick trip to the town, Dr. Steer immediately knew that there was a problem. The family of 6, all of whom had suddenly developed arthritis, also knew several other people who had developed the disease as well. With help from his old colleagues at the CDC, Dr. Steer set about identifying as many cases as he could. Much to the surprise of the newly formed investigational team, however, this was not nearly as difficult as they had imagined. In a community of this size, word of all of these people suddenly developing debilitating joint pain had spread like wildfire. Many of the families that the investigators spoke to knew of at least several others who had also come down with the affliction. On some streets, investigators were alarmed to find entire rows of houses with an affected child. Overall, they were able to find 51 cases. Alarmingly, 39 of these were children. When interviewed, almost all of them told the same story. They had experienced a sudden, painful swelling in one of their joints, usually the knee. This was often accompanied by a high fever, with some even developing headaches, muscle aches, and fatigue as well. This lasted for, on average, about a week, but a handful of patients exhibited constant pain and swelling for up to 6 months. Most, however, got better relatively quickly, only to be struck down again several more times in the coming months. By the end of their search, the team had meticulously put together a map of the locations of all of the cases in the town. A pattern clearly emerged in the data. First, relatively few people in the more crowded downtown areas had been infected, indicating that, fortunately, the disease was probably not transmissible between people. Second, the vast majority of cases occurred in the more heavily forested area. And third, the majority of cases experienced their first bout of arthritis in the summer. For those who were trained in epidemiology, this was a classic story of an insect-borne disease. Once the epidemiological investigation was concluded, all of the patients were asked to see a physician at Yale. This doctor meticulously examined each and every one of them, including a thorough medical history, a physical exam, numerous blood tests, and in some cases, even direct drainage of the fluid from the afflicted joint. At that time, there were a handful of infectious diseases that were known to cause sudden onset arthritis. The patients were, of course, tested for these, as well as dozens of other infectious causes. Many of them had been ill for quite a while and collected a whole host of specialists in that time who were now involved in their care, including pediatricians, rheumatologists, orthopedic surgeons, and in some cases, even ophthalmologists. The investigators contacted all of these doctors to request as much information as possible on the patients. Ultimately, the team was able to rule out all known diagnoses, infectious or otherwise, that could possibly explain the cases. One piece of the puzzle, however, provided a tantalizing clue. About a quarter of the patients remembered developing an odd, target-shaped rash several weeks before the onset of symptoms. Impressively, the team did a thorough review of the literature on rashes. It was certainly not the most exhilarating topic they had reviewed in their careers, and found this to fit the description of an obscure lesion by the name of erythema chronicum migrans. This disease, first described by a Vienna dermatologist by the name of Benjamin Lipschutz in 1913, who suggested that the disease might be caused by the bite of a tick. Many other physicians over the years had described a similar rash, including at least 6 outbreaks in Scandinavia, 1 in Austria, and interestingly, 2 outbreaks in Connecticut. Still, none appear to have made the connection between the rash and arthritis, likely due to the extended period of time that usually lapses between these symptoms. Even Dr. Stier was uncertain if they were related, but concluded in his original report that he believed they were. At this point, he felt confident that he was looking at an as-yet undescribed disease, which he chose to name Lyme arthritis, after the town in which he had found the outbreak. Despite his extensive testing of the patient's blood and joint fluids, Dr. Stier had not been able to isolate a specific causative agent. He suspected the pathogen to be viral in nature and recommended that patients take aspirin until the infection cleared. This was, at best though, a speculation on his part. Still, he was undeterred. He had been able to determine that the vector was almost certainly a tick bite, but he was still curious about that target-shaped rash that he had seen. So he sought out and found 38 more people in the area who were currently experiencing a similar rash. Sure enough, over the following year, almost all of them went on to develop the classic swollen, painful joints. As he was able to observe this group more closely from the start of their clinical course, a disturbing pattern began to emerge. This pathogen, whatever it was, did not just target the joints. 2 patients developed a condition known as Bell's palsy, in which the facial nerve becomes paralyzed, rendering one half of the afflicted patient's face unable to move, somewhat resembling a stroke. One patient developed persistent numbness wrapping in a belt-like distribution around his lower abdomen. 2 had a bout of meningitis. 2 patients even developed persistently irregular heart rhythms due to damage to the electrical conduction pathways in this organ. He was confident now that it was a tick-borne disease, and that prednisone appeared to alleviate some of the symptoms, but it was only at best a temporary fix. With these patients, he widened his net, testing for hundreds of infectious diseases. Still, he found nothing. It would be 6 more years until another scientist, Willy Burgdorfer, would isolate the bacteria from deer ticks in New York State. In his honor, the new bacteria, Borrelia burgdorferi, was named after him. In determining who exactly discovered Lyme disease, the story becomes quite complex. By most standards, Dr. Stier and the CDC team were the first to put the entire constellation of symptoms together as one cohesive disease process. Therefore, they deserve the credit. But physicians had described at least some components of Lyme disease dozens of times in the literature before. It was not a new disease which had made the jump to humans relatively recently, like some pathogens, but by all accounts it was actually a very ancient disease, having been with us since at least before antiquity. The best evidence for this comes from Ötzi, the famous 5,300-year-old mummy found in the Eastern Alps in 1991. A DNA sequencing study performed on the mummy in 2011 showed that his body contained DNA from Borrelia burgdorferi, suggesting that he had likely become infected with the pathogen at some point, probably later in his life. For thousands of years, the disease was just one of a countless number of lethal illnesses that were part of everyday life for humans. It's difficult to tell where exactly this little microbe first gained its ability to infect humans, but it has been present in the northern latitudes, predominantly in the northeastern United States and across much of Europe, for millennia. Determining who first described Lyme, though, is a difficult task. Lyme produces a great variety of diseases as part of its invasion of the human body, and can present vastly differently in each patient. As noted previously, it starts often with a classic bullseye or target-shaped rash, but it can also start with a different type of rash known as erythema migrans, or migrating redness. One would think that it would be easy to correlate this rash to a tick bite, but studies have shown that most people who develop the disease do not recall being bitten by a tick. Soon, most, though, will experience a flu-like illness, which improves in about a week, but might continue with chronic headaches for months. As the bacteria progresses through the body, it can cause facial nerve paralysis, numbness, inflammation of the heart and the brain, as well as wandering joint pain. In its later stages, after months to years of infection, it finally produces the classic red, swollen joint. As these symptoms slowly evolve over the course of months to years, it can mimic a number of different diseases. Because of this, various aspects of the disease have been described for hundreds of years. Likely the first description of Lyme came from John Walker, a Scottish minister and a natural historian, which is a sort of precursor to the modern biologist. In a visit to a small island off the west coast of Scotland in 1764, he described a disease which produced a substantial amount of joint pain, which he believed to be caused by the bite of a, quote, worm of reddish color and of compressed shape, with a row of feet on each side that penetrates the skin. In other words, a tick. It would be over 100 years before another researcher in Germany would describe a degenerative skin disorder, acrodermatitis chronica atropicans, in 1883, now known to be a rare complication of Lyme. In the 1910s, a pair of researchers, one from Austria and the other from Sweden, would both independently describe the classic migrating target rash of Lyme, but would fail to make the connection to later complications such as joint disease. Just a few years later in the 1920s, a pair of French physicians would describe a disease which caused neurological symptoms and meningitis caused by a tick bite. These doctors even noticed a large target-shaped rash on the patients, but for unknown reasons, they failed to make the connection to the patient's other symptoms. In the 1930s, a Swedish physician, Sven Hellerström, came very close to completing the picture, proposing that the tick bite, rash, and neurological symptoms were all related. In the 1940s, a German neurologist by the name of Alfred Bannerworth would describe the neurological components of the disease in greater detail, coining the condition Bannerworth syndrome. Probably the greatest advancement of this era was made in the 1950s, though, when Swedish physicians and researchers suspected that the rash and the neurological symptoms were caused by a spirochete, which is a type of spiral-shaped bacteria. While their reasons for believing this were erroneous, they actually happened to be correct, and Borrelia was later shown to be part of this class of bacteria. They soon began treating patients with the best agent available to them, penicillin, which proved surprisingly effective and was adopted all around Europe for the treatment of Bannerworth syndrome. In the time before Dr. Stier had fully characterized Lyme, its various symptoms had gone by a number of names. Just a sample of these includes Bannerworth syndrome, Alphezius disease, Montagny, sheep tick fever, and Guerin-Bougedeau syndrome. Thankfully for modern listeners, medicine has largely moved away from the practice of naming diseases after their discoverers, greatly reducing confusion amongst patients and medical practitioners alike. After Dr. Stier characterized the disease, and Dr. Burgdorfer isolated the pathogen, the floodgates were now open to make huge strides in the diagnosis and the treatment of the disease. Nowadays, Lyme disease is widely recognized, with most Americans, particularly those living in the northeastern parts of the country, being aware that tick bites carry a risk of transmitting this ailment. The good news for most is that a tick usually has to be attached for a relatively prolonged period, typically about 36 hours, before there is a risk of infection, meaning that there is much benefit in doing a routine tick check of your skin if you've been in a high-risk area, such as on a hike through a New England forest in the summer. Even if it transmits its microscopic hitchhiker into a person, then antibiotics, almost always in the form of doxycycline, have been shown to be highly effective at eradicating the invader. Still though, some of the more severe manifestations, such as facial nerve paralysis, neurological deficits, and electrical issues with the heart, can persist for long after. Some people even report having lasting symptoms of pain, fatigue, and concentration issues after completing treatment, in a constellation of symptoms known as post-treatment Lyme disease syndrome. While there is much controversy surrounding the diagnosis of this ailment, several large studies have shown the once popular practice of treating this disease with long-term antibiotics to be ineffective and potentially dangerous, increasing the risk of acquiring other life-threatening infections through the induction of antibiotic resistance, as well as damage to the gut microbiome. Despite our advancements in the prevention and treatment of this disease, there are still almost 500,000 cases diagnosed in the United States alone every year. In 1998, GlaxoSmithKline released a vaccine, Lymerix, which was shown to produce immunity in 76% of adults. Unfortunately, though, it became a tragic victim of the anti-vaccination hysteria that was reaching its zenith at that time. Andrew Wakefield, the disgraced doctor who alleged that the measles, mumps, rubella vaccine caused autism, published his incredibly damaging and since thoroughly disproven paper on the topic earlier in that year. Soon after, several people who had received the Lymerix vaccine came forward, alleging that they had suffered a variety of lasting effects due to the vaccine. Despite thorough investigations by the CDC and the FDA, which found no connection between the vaccine and the alleged side effects, a number of highly publicized class action lawsuits were filed against the manufacturer. Under the pressure of these lawsuits, as well as a reluctance of insurers to pay for the vaccine, and a general public fear precipitated by sensationalized news reporting on the alleged side effects, GlaxoSmithKline pulled their vaccine from the market in 2002. Recently, though, attempts at producing another vaccine have shown much promise, with Valneva receiving FDA approval for their vaccine in 2017. As of 2025, rights to manufacture the vaccine have been purchased by Pfizer, and clinical trials are still ongoing. As of now, though, it appears that this ancient bacteria will continue to plague us for years to come.